Like I said, thoracic is something that's very close to my heart, and it serves actually more like as an anecdote also. Endobronchial carcinoids are one of the very rare variety of cancers. They are, to understand it in simple language, it's like a small mushroom growing inside your airway. And it's like a mushroom has a little stump and it has a bulb on the top, and your airway is like a pipe that takes the oxygen down into the lungs. So if one of these ping pong balloons sitting over there just decides to choke up one of the airways, that part of your lung doesn't function. So it's a tiny little thing sitting there, but it can completely compromise a component or an entire lung also. So this dates back to a good 6-7 years. It happened so incidentally that a young boy, the incidence for carcinoids is in young boys. So a 32-year-old young chap was admitted at a South Bombay hospital. And because he stays in Thane and his father had been treated for advanced lung cancer under our care, he transferred back to the intensive care in Jupiter. And I got a call from there. He has one lung that's completely collapsed. And the pulmonologist wanted me to scope him to find out what the issue was. And when we scoped him, we found this little carcinoid choking the left main bronchus. It's the branch of the trachea, the windpipe that goes to the left lung. And that's why the whole left lung had collapsed. And we needed to operate to remove that. But he wasn't fit enough for surgery because he was breathing on one lung. So what was planned was actually as an interim procedure to do a bronchoscopy, a small scope that goes in there. And we use a laser, again, technology to burn out that bit of the mushroom or the tumor to channelize and open the air passage so that the lung gets ventilated or gets air going inside. And we started the whole process with that, and the patients kept a little awake. It's awake sedation, we call it. Like he's sleepy, but he's kind of breathing himself. Mm-hmm. And I started the process. It was one of my first then attempts to do that. And it took a good long 2.5, 3 hours, but it came out so well that at the end of it, we had practically debulked the entire tumor. There was nothing left at the end of it. And a week later, he was scheduled for actual surgery. And that actual surgery amounted to opening the entire chest bone, going behind the heart, removing a bit of that windpipe, and then rejoining it back. So major surgery for a young boy. So a week later, when I rescoped him planning the surgery, and I saw there was nothing out there but a scar. So somewhere my conscience wasn't justifying doing such a major surgery for just a small scar. And I took a frank opinion of a lot of my seniors in the city and from esteemed institutes. And they came back telling me that there isn't enough data to prove that what you've done is enough. But it's such a rare cancer. And if he's going to be diligent on follow-up, we are game with it that you could just keep him on observation. The boy has been on follow-up regularly and has even migrated now on an IT job to LA, and he does communicate regularly. So that was started out a series, after which actually that encouraged me, and I've dealt with a lot of these tumors endobronchially. They're of course few and far apart. They don't come that frequently. It's usually 1 or 2 a year that we get by. But it saved the patient a portion of his lung and a major surgery.